This patient was referred to me for endodontic retreatment of tooth number 3. According to the patient, this root canal was done originally about 5 years ago by her previous dentist. And patient says after that, she didn't have any symptoms with the tooth. About 9 months ago, a dentist tells her that she has low-grade infection associated with the tooth and the root canal will need to be redone. And patient agrees, believes the dentist and agrees. Another dentist, not an endodontist according to the patient, this is a group practice, so patient says another dentist then at a later appointment about 9 months ago or 7 months ago redid this root canal for the patient in one appointment and told the patient that there was a missed root. I'm assuming that there was an MB2 there. And this dentist could find. And the root canal retreatment is completed in one appointment. And as you can see, now tooth has a crown on it. But the patient told me yesterday that the tooth, after the root canal was redone, the tooth hurt a lot. There was a temporary crown even on the tooth, and patient kept complaining to the dentist that the tooth hurts a lot, and the dentist prescribed multiple courses of antibiotics for the patient and told the patient everything was okay. And perhaps this was normal, and sometimes it would take a year or two for the pain to go away. So that dentist proceeds to put a post in the tooth and build the tooth up and crown it. And patient still had pain when the dentist did all of that. Now, 7 months has gone by, and patient changes dentist, goes to another dentist, and patient says that she can't even touch her face from the outside. Touch her face. Patient says when she washes her face and touches that area on the outside, it hurts. So the new dentist referred the patient to us for evaluation and endodontic retreatment. So I'm looking at this tooth, and clinically, percussion, tender, palpation, extremely tender. When I went up there and palpated just superior to tooth number 3, very lightly, very gently with my finger, patient jumped out of the chair. There was a lot of pain there. What do we do next? So we did percussion, percussion tender, palpation extremely painful. Now the next thing we do is probing. All right. Let's look at multiple angulation PAs and see what we see first, and then we'll go to probing. Okay, so in this angulation, you can see the periapical relucency associated with the palatal root. Look at the periapical relucency associated with the MB root. The gutta-percha is overextended there. All right, but you can see the shape of this periapical relucency that's associated with the MB root, right? J-shaped, right there. That's a sign. That's one sign that you need to pay attention to. And again, you can see it here. You can see the overextended gutta-percha. You can see the periapical relucency associated with the palatal root. And look at this. Look at that widened PDL. Right there, overextended gutta-percha there. All right, so let's go ahead and probe this tooth. Now, before I show you the probing of the tooth, we were able to get some x-rays from that dentist who redid the root canal. Okay, so take a look here. He started with this right here. You can see there was a post in the palatal root, and this was the condition of the tooth. All right. You can see here that looks like he's removed the post and is trying to remove the gutta-percha and everything else. And right there. and right there, and that's another x-ray with the files in the canals, mid-treatment or retreatment in this case. All right, what's missing here? What's missing here? There are files in the canals here and here. What's missing? Where is the rubber dam clamp? I don't see a rubber dam clamp. So I show a patient a rubber dam. I pull a rubber dam out of our drawer and show the patient a rubber dam and ask the patient, was one of these used during the root canal retreatment when the dentist a few months ago redid this root canal? The patient said no. Nope. It was not used. Rubber dam was not used. So remember, rubber dam is mandatory in endodontic treatment and retreatment cases. Rubber dam is mandatory, and here rubber dam was not used. All right. So on the buccal side, the probings were 2 to 3 millimeters. On the palatal side, right here, you can see that there's a deep pocket right here. Right there, I'm getting 6 millimeters right here on the mesiopalatal aspect of the tooth. Okay. All right, very good, that's it. As you saw, unfortunately, there's a vertical root fracture associated with this tooth, and this tooth, unfortunately, has a hopeless prognosis and will need to be extracted. This tooth did not fail. The endodontic retreatment did not fail because the gutta-percha here is overextended. Okay, the endodontic retreatment failed because there was no rubber dam used, and there was no rubber dam used during endodontic retreatment a few months ago. And the mesiobuccal root is vertically fractured. It is possible that the mesiobuccal root was already fractured before this dentist redid the root canal. That's a possibility. Perhaps maybe this tooth was misdiagnosed a few months ago when endodontic retreatment was done on it. I don't know. But based on our radiographs and findings and tests, unfortunately, this tooth needs to be extracted now. So the overextended gutta-percha did not cause endodontic failure. What caused endodontic failure was not adhering to the fundamentals of endodontics, perhaps misdiagnosis. Perhaps this, as I said, MB root was already vertically fractured. I don't know. But it is now. So we were able to diagnose properly. We examined this tooth thoroughly, did our homework, didn't go immediately to endodontic retreatment of the tooth. Remember, all starts with proper diagnosis. Now, this patient will have this tooth extracted, area bone grafted, and then we'll get a dental implant.